How many people in here over the last 2 years have started doing telehealth when you didn't do it before? So I started doing telehealth in 2014. The Veterans Administration actually had encouraged telehealth a long time ago, and here's why. Within the veterans system, I can refer to specialists in other places just by entering a thing into my computer. So in 2014, I set up a program. Actually, I participated in setting up a program where I would send patients to the Palo Alto VA, which is affiliated with Stanford, for anybody who needed extensive head and neck cancer surgery. And then when my patients would get home and go home to Silver City, Farmington, Taos, Raton, I would set up a telehealth follow-up with them so that I could see patients both ways. I could refer them out. I could also then see them and follow them up. So I've been doing telehealth for a long time. Now, having said that, let's talk about the differences between when I set up that program back then and now. All right, we're going to have this issue again. Where is my cursor? Okay. So definition of telehealth. And first of all, I don't have any disclosures except that I work for the federal government and I am here to help. From the Greek, tele, far, telos, end, combined with medicine from medicina in Latin. The delivery of health-related services and information via telecommunications technologies is one definition. The use of medical information exchanged from one site to another via electronic communications to improve a patient's health status. Telehealth includes preventative medicine, includes promotive medicine, and curative medicine. Now, as nurse practitioners, what do we like to engage in the most? We want to engage in those things that are happening before the patients get sick. So unfortunately, as a specialist, most of what I do, unfortunately, is curative or attempted curative, but we want to engage in promoting good health and we want to engage in prevention. Telehealth only includes, or telemedicine only includes the curative aspect. So that definition between telehealth and telemedicine. Medicine is the curative aspect, diagnosis and treatment. And as nurse practitioners, we really do the former. Modes, telephone, that's audio only. Live video, that is synchronous, clinical telehealth. Store and forward, which means take a picture and look at it later. And then remote patient monitoring and mobile health. All of those different things go into telehealth. Telephonic is audio only. No examination of the patient except by their verbal description. As a consultant, I get concerned when somebody sends a patient to me. So for the last 2 years, I'm not blaming you primary care folks, but you're talking to the patient on the phone. You're getting their history. How are things going? Is your medication working for you? Have you been taking your blood pressure, et cetera? You're not seeing the patient. But I found it especially true in the VA. It was very easy for those primary care providers to pull the trigger on, I'm not going to see people face to face because of COVID, but I'm going to send you to a specialist in ear, nose, and throat who has to get that close to their face and look in every orifice, from the neck up. So sometimes it was kind of like, I wish that you had taken a look at the patient, but anyway. And then when I would look at their electronic medical record, if I saw WNL, that meant we never looked, okay? So synchronous video is what most people nowadays think of as telehealth because technology has advanced. We're not just doing phone calls anymore. We're actually seeing patients face to face on video. And it depends on the platform that you use. So some people use Zoom, some people use other platforms. In the VA, we have our own because, the government has to be, very, very tight with HIPAA and all that kind of stuff. It has to be secured communications. So synchronous means that both the sending and the receiving area are on at the same time. So this can be used for consultation, it can be used for diagnosis, and it can be used for treatment. And it's very useful for me, for patients who live remotely, to do post-operative visits so that they don't have to come all the way back to my place to be seen. So this is the ultimate in synchronous medicine. This is the Vinci Robot. The Vinci Robot now is into its second generation of things that they can do. And the surgeon who controls that Vinci Robot could be sitting in a booth in Alaska and controlling the surgery in Alabama, okay? So potentially this kind of thing is going to be more and more as the technology continues to advance. So it's pretty kind of cool. Of course, this is what the patient feels like. So store and forward, this is asynchronous telehealth. Every time you send out a request now for somebody to get an x-ray, it is very likely that that x-ray is going to be looked at remotely, because radiologists have been doing this type of stuff for a long time, for years. So it's defined as transmission of recorded history, other information about the patient, images through a secure electronics communications means. The provider then renders an opinion and may then ask for further workup from you, the primary care provider. Or the provider may, or that the person who's looking at the imaging may want to do face-to-face or synchronous video telehealth follow-up. So again, radiology has been doing this for a number of years. They dictate those reports, and then you look at the report. I also look at the x-rays, because when they're doing a large volume, and a lot of these get looked at in the middle of the night someplace, I look at the images myself, because I have frequently found things that are not mentioned in the report that are important to me as a consultation provider. So current store and forward programs in the VA are Teledermatology and Teleretinal, which is very handy. There are dermatology practices that are beginning to set this up. Send me a picture, and then we'll see if we actually need to get the patient in and see them. Teleretinal has been around for quite a while. They take a picture of the images of your retina. This is very, very useful for screening people for diabetic complications on the retina. So this is a program that we already have. I am working with our telehealth department. I have been for the last 2 years to set up a tele-ear program. Now, the way the VA works in New Mexico is we have CBOCs, clinical-based outpatient clinics. They're all around the state. We have some that are contract clinics like TRC and Taos. We have some that are open permanent clinics with permanent VA physicians and other healthcare providers. And so what I'm trying to do is get them to go to that CBOC, get a picture, because we now have the technology in all of the CBOCs, but patients can do this. I had a patient recently where we got a consult about him having some kind of a drainage in his ear. So I called the guy up and I said, hey, let's do a televisit instead of an in-person visit, because you live in Silver City or someplace. And instead of having you come all the way up here for me to look in your ear, let's see if we can do it with the camera on your phone. Well, he was having trouble with a lot of excess wax in his ears. So over the counter, you can buy a video camera that's about the size of a pen, fat pen, that also comes with an ear cleaning scoop for about 23 bucks. So he had recently purchased one of these mini cameras. He made it talk to his iPhone. And so I said, let's set up the telehealth. We set up the telehealth. He then shared his screen off of his iPhone, and I could look in his ears. I could look in his throat. I could look up his nose. I did ask him to clean it between orifices, to say. So we're working on setting up tele-ear. A picture sometimes is worth 1,000 words when you're looking at small places. Remote patient monitoring. So this actually goes all the way back to NASA. So NASA was figured out that we need to keep track of these guys when we're going to send them out of this world, literally. So it can be real-time telemetry. Like there are some of you, I think our critical care fellow back there, in your practice as locums, have you gone to places where you're doing remote monitoring of some of those patients? You know, that is something that can be done. It can be video, like a tele-ICU, where you can actually look at the patient. For primary care, it might include, you know, a survey of the patient, have one of your folks in your office do this, you know, ahead of time, go down the HPI, you know, listen, you know, to what all the things they have to say, and then actually talk to the patient. Mobile health is defined as healthcare, public education, or state-of-the-art practice that's supported by things such as tablets, smartphones, and smartwatches. During COVID, the hospital shut down. We didn't let anybody come in, which I think is a crime. I think that was ridiculous. I think that should have never happened. When people were dying in the hospital, their family couldn't even be with them. So the hospitals had to jump, and actually it was a lot of the nurses that provided technology to say, we're going to get you with your family anyway. So the nurses started whipping out their smartphones. The hospital said, you can't do that because of HIPAA. So then the hospitals provided tablets or some other devices so that you could visit with your person as they were dying. Again, I was not a big fan of shutting down the hospitals. I think people could have been given protective equipment and hand wash and be able to come in and visit their dying loved one. But technology filled the gap during that time period over the last couple of years. Some hospitals are still shut down and don't allow that much visiting. And I'm not for that. There are some apps that you can use that include diagnostics, that include calculations, information about disease processes. I mean, all of you should have at least 2 or 3 apps on your smartphone that you use on a regular basis for the type of patients that you see in your panel. You know, whether it's a diabetes app, whether it's a, you know, how to get a hold of the end-of-life people, whatever. There are a lot of apps out there that you can use. Mobile health is not talking to your patient while they're driving. That's happened to me more than once. I set up a telehealth program, you know, I set up a telehealth visit with one of my patients, and I log into the system. They log into the system, they're driving down the road. Please pull over. We're not going to have this conversation while you are driving your automobile. So, I mean, this happened right from the start. So if you could see the caption on that, it says, now I want you to steer with your knee as you talk on the phone, eat some fast food, put on your makeup in the rearview mirror. Yeah, we shouldn't be multitasking. And I kind of spank Shauna about that, because a lot of times in our meetings to set up these this conference, she would be driving as we were talking. She's one of the members of our committee. So a VHA telehealth definition, of course, the government has to make it a lot more wordy. The wider application of care and management principles to the delivery of healthcare services using health informatics, disease management, telehealth technologies, and to facilitate access to care and improve the health of designated individuals and populations with the intent of providing the right care in the right place at the right time. Doo-dah, doo-dah. History depends on the definition. So how far back does telehealth go? Well, so if you define it as using communications to exchange information over distance, could go all the way back to the telegraph. If it's, as we assume now, it includes television for remote healthcare, the history goes back about 60 years. Here in the Southwest, because it's rural, a little bit of military, do you know a lot of NASA stuff was done in New Mexico? Those of you that are not familiar with that should visit Alamogordo. Next time you go to White Sands, make sure you go to the museum in Alamogordo, the Air and Space Museum. New Mexico has a long history of participating in this. In the early days, they were ones that pioneered telemetry and telemedicine here in New Mexico and Arizona. And by golly, we even communicated with Armenia. Arizona in 1972, they set up a program. The program was called StarPack, and it was with the Papago tribe. So they wanted to know, how can we test this before we send people out of the world? Well, so they used early transmission technology, microwave technology, to monitor some folks in the Papago tribe in Arizona. And then in 1988, because they had developed all this technology and we were sending people to the moon, we were doing all kinds of other stuff, they communicated with Armenia when there was this huge earthquake, and NASA provided some telemedicine, which was kind of a nice non-military application of that type of technology. So it was helpful to providers there. So more NASA today, they continue to develop things, you know, if there's, let's say, an injury on the space station and they need to deal with it, they're developing things like ultrasonography for the astronauts, teach them how to use it, researching the technology to monitor bone loss, because that is a problem when people are up in space for a long period of time, treat fractures with low pulse sound waves. And New Mexico's Loveless Hospital, although now owned by a larger corporation, was originally developed to be an adjunct to NASA. All of those astronauts back in the day, that if you go back and look at some of the early video and stuff, and a few of us that are old enough to remember the space missions, when those guys would splash down in the ocean and they would pluck them up and they would take them to the carrier and put them in that, it was a Airstream trailer that was parked on the deck of a carrier. And they would stick those guys in there and put them in isolation, because after we sent them in space, we didn't know if they were going to bring back things that could be potentially harmful. So those guys would then be transported in that Airstream trailer to the Loveless Hospital for their 30 days of isolation. So that was kind of an interesting part of Loveless Hospital back in the day. Loveless also participated in all the high altitude training for the bailout at high altitude and all that kind of stuff. Some of the stuff that has military applications. They shared that technology in 1967 with Boston's Mass General Hospital, which linked to Logan Airport so that they could provide emergency medical care support to people at the airport. And in 1971, the first satellite link for telemedicine was tested to 26 remote communities in Alaska. So Dr. Loveless and high altitude telemetry, Dr. Richard Luker. Okay, yeah, Joyce is laughing. Dr. Richard Luker was at Presbyterian Hospital. I worked at Presbyterian Hospital starting in the late 1970s. He was one of our cardiologists, kind of a happy-go-lucky guy. Just a fun fact about him, we not only had his phone number, his pager number, but we had his wife's phone number, because he would sleep through pagers and phone calls. So he had to pay, you know, if you got through the first two numbers and he didn't respond to you, you had to call his wife to go in and wake him up so you could talk to him in the middle of the night. Anyway, he set up a remote link for telecardiac rehab between Albuquerque and Gallup, so that we could do telecardiac rehab. And this was a number of years ago. Other New Mexico history with telemedicine, Project Echo. Anybody in here participate in any of the Echo projects? Yeah, so when I said this about 4 years ago at this kind of a lecture, 1 or 2 people raised their hand, but I'm glad that many of you are participating in different types of Echo programs. More high altitude telemetry stuff, telecardiac rehab. So again, it was between Newhart and Gallup, prevented ER visits because they were able to monitor some of their congestive heart failure problem, you know, people that had problems. There was one-to-one progress visits when people were in this rehab program. And then later on, they provided classes using the Echo model where the patients could come and sit in a lecture place and be remotely informed about their disease process and ways to avoid going to the ER. So Project ECHO in New Mexico, Extension for Community Healthcare Outcomes, started in 2003. Originally, the program was set up to provide liver failure information to primary care providers all over New Mexico. You know, Espanola and that kind of northern part of New Mexico is one of the highest heroin use places in the world. And unfortunately, there's also a lot of liver failure up there. So they originally set that up so they could provide support to those providers. The providers could literally once a month call in, ask their questions, get support. And that way, all the patients didn't have to come to Albuquerque to be treated at the University of New Mexico. They would share that knowledge freely. And so that has now blossomed into worldwide ECHO programs in just all kinds of medical disciplines. And they're even using the ECHO model in other things now too. Businesses latched onto the ECHO model. So it's basically sharing specialist knowledge with primary care providers and partnering in that care. And you literally could call in to an ECHO person there and get a teleconference with them and ask specific questions about your patient. How do I treat my patient? What, you know, antivirals do I give them for HIV or you know, et cetera. So really a highly successful project. Dr. Sanjeev is right now actually working with a project with India to do the same thing. So from New Mexico, providing healthcare in India. And then, you know, going back even farther, in 1964, there was the Nebraska Psychiatric Institute and the state hospital. They used a closed circuit loop to exchange information. So back then, the grant ran out and they considered it to be too expensive to keep going because they were waiting for the technology. Well, let me tell you, technology is here. Teleretinal, diabetic teleretinal imaging, 10,000 images a year are scanned in and looked at remotely by specialists in Albuquerque and Tucson, and they screen for diabetic type of things. Teledermatology, same thing. They send in these pictures to our derm department. Our derm department says yes or no, it's probably not worrisome, or yes, we need to see them, or somebody in the community needs to see them soon. And then they can do face-to-face telemedicine if they need to, and get them into timely referrals. Store and forward, this is a non-medical application of store and forward. Game cameras set up to capture poachers. Another semi-medical sidebar, this happened about 6 years ago. My elderly neighbor thought that his grandson was stealing his Percocets. So he set up his iPhone as a store and forward camera with an app that was available, and he did catch his grandson. Got his grandson into rehab, and I'm happy to say a number of years later that he is happily married and staying on the straight and narrow. So VA telehealth, telemedicine post-op clinics for ambulatory surgery patients, CHF focused telemedicine and with Humana, pre-surgical evaluation. That's what I was talking about that I started in 2014, where I would work the patient up. They would have a face-to-face with the surgeon from Palo Alto. They would fly out to Palo Alto, get their surgery on Friday, come back to me on Monday or Tuesday. I would do all the follow-up. And then there was a VA insider story about IT supporting telehealth nurse practitioners in the field, and that is nurse practitioners who were doing homeless visits in LA and San Francisco. So COVID, compared to 2014, Tele-ENT initiated in Albuquerque. Around that time, there were only 10 states that were reimbursing for store and forward technologies, 13 that were allowing payment for remote monitoring, 4 states didn't reimburse at all for live video. 24 states reimbursed for only the sending healthcare provider, did not reimburse the consultant. Medicare and VA only had 2 telehealth codes. So there was not a lot of incentive to do it, but COVID has changed things. So most of you now are participating in telehealth in one way or another. And for those who aren't, you will be. That's just the way the technology is going. Changes to reimbursement because of COVID. The big deal is that Centers for Medicaid Services, the VA, video encounters are now considered exactly the same as face-to-face for billing, okay? But you have to use the correct codes. Work credit also has bumped up. So RVU, everybody's under that RVU calculation for your work credit. The work credit bumped up. So the work credit bumped up significantly. Work credit for a telephone follow-up now is higher than a face-to-face code for some types of CPT codes. So like a face-to-face or a video 99214 is 1.5 telephonic 31 minutes versus 2.1 for the telehealth code. Not quite apples to apples, but you kind of get the picture that, you know, we are good actually getting decent reimbursements for this. One of the keys that I want to tell you though, if you engage in telemedicine, is not just bill that like a face-to-face. You want to put something down on your note at the end or at the beginning that says, I spent this amount of time reviewing the chart and documenting, and I spent this amount of time actually talking to the patient, okay? It's the time codes that make it easier for you than having to do 21 check boxes of a physical examination. Does that make sense? The time codes are just as good for reimbursement as doing 21 check boxes for history and physical. So some of the nuts and bolts of this, the correct encounter ensures that you have the proper billing codes, the proper RVU. Unlike private practices at the VA, we don't have anybody to do this for us. We have to actually do our own coding. We do have coding audits from time to time, but we actually have to do our own coding. There's more than one way to do an encounter, but only one best way. So bear with me. Government tedious processes. So the VVC clinic, a good thing for you to do in your private practice to actually set up time set aside to do video visits or time set aside to do telephone visits, okay? If you set that time up ahead of time and build into it a little bit of extra time because not everybody can handle the technology yet. I know I deal with old men as my primary group of patients, okay? So the technology is sometimes difficult for them, and bandwidth in New Mexico is an issue, all right? So I may set up a video visit with somebody in Raton or Silver City or somewhere else, and what ends up happening is it turns into a telephone visit because I get a hold of them, they follow all the steps on the email that I send them, and I only get audio and not visual. It's because of bandwidth. It has to do with not having that high-speed connection. So if you can actually see the patient, then you can bill for synchronous video. If not, you're going to use the correct codes for a telephone note. One of the things that the VA instituted and many other insurances have as well is that there are no copays for video visits or telephone visits. Okay, that's important to patients too. If they're not having to spend 40 or 100 bucks or whatever, not having those copays. Write your note, add that disclosure at the beginning or at the end, make sure and put that the person consented for telehealth, okay? And then we also in the government, they have to make it harder for us because we work for, the government. So we have to put the disclaimer in there that the patient not only has consented to it, but we also have to say that there is emergency backup in case the person goes nuts on the phone at the end. There is emergency backup in case the person, starts to have a meltdown. There is an emergency number for me to call to have somebody go check this person if they're freaking out. So anyway. And at the end, again, you want to document your time. Document your time. I need to emphasize that one more time. You need to document your time. So this is what it looks like for us. Synchronous telemedicine service. Look up the CPT code for that. It's a 95 on top of your 9921 whatever or 31 whatever. Then there's a secondary code that you want to also click, and that's if you see the person face to face. That will cover you for Medicare, Medicaid, insurance companies. Document those codes. Add that modifier. And then you can't see this, I can't see this, it didn't scan in well. This is the difference in our view between a face-to-face visit and a video visit. So it actually, video visits now are the same as. So again, our view for a visit can be 2.1 versus 1.5, bumps it up a bit for you. So at the beginning of this fiscal year, which for the VA starts in September, they told us that the goal for all providers is going to be 50% telehealth by the end of this next fiscal year. Now, that is working somewhat for our primary care providers, but as a consultant who has to look in the ear, nose, and throat, I'm a little bit behind on these. We actually got told within our division, you will do a minimum of 96 televisits between now and the end of the fiscal year. I'm a little behind. I've got a few, but anyway, are you ready? There's always a turkey in the mix. This actually was a picture from my backyard. I live in Sandia Park. Obstacles. So the most obvious is lack of hands-on, the online training modules that they started me with when I started telehealth in the VA back in 2014, there were 6 online modules that took a total of about 15 hours to go through. It was ridiculous. It was typical government, onerous, lot of stuff. And even for your own telehealth training, I don't know what you get in your various organizations, but most of it's written by computer geeks. It's not very friendly. It does not intuitive, except to them. So, some patients don't trust it. Bandwidth is a real issue. Telehealth encounters, you have to have your backup procedures. Same day clinic, urgent care. Yeah. So you've seen, unfortunately, and I'm not blaming the people who provided the technology for this conference, but, we paid $80 a piece for these and they haven't worked. Really disappointed, really. And it's not the people who provide the technology for this. This was separate. This was outside their purview. Some informative websites where you can go find out more about telemedicine: American Telemedicine Association, Center for Connected Health Policy, Telehealth Resource Center. These are all good places to look at for reimbursement issues, for ways to do it better, helpful tips and tricks. Any questions about telehealth? Yeah.
So my question is, I've been using the EM codes, but not the CPT code. Is there a difference in reimbursement when you add that CPT code?
Yes.
Okay.
Yeah, if you add that synchronous video telehealth one, then
It goes to the
then
2.1.
It's a face-to-face.
Okay, thank you.
Yeah. Way in the back.
So place of location. There are different codes for place of location. 02 versus 10, I believe. Does anybody else know about that?
Speak a little closer.
Oh, okay. Place of location. 02 versus 10.
Right.
Does anybody else know about that and how those are used appropriately with
So
the
that's some of the
95?
updates to the telehealth coding since I first started doing it. So back when I first started doing it, the only one that got credit for telehealth was the sending person engaging in telehealth. So since then, of course, with the update to ICD-9 codes and CPT codes, there are now several telehealth codes. Look those up, take a look at those, look at the definitions of those, and that'll be helpful for you knowing which ones to use. But again, most of those now are related to time. How much time did you spend with the person? Was it 10 minutes or less? Was it 10 to 20 minutes? Was it 21 to 30 minutes? Or was there extended time beyond that? And again, you can count your review of the chart and the amount of time that it takes you to do your documentation when you finish. So include that all together with your time spent with the patient.
Okay, but I think I'm talking about place of location. In other words, when the person is somewhere else and not in the office,
That's correct. Yes.
then they have a code that is different than the office location code.
No. You use your same 99214 or 99315, or
Okay.
use that same code. But then when you add the synchronous video telehealth, that's when it becomes a video visit.
With what modifier?
95.3.
95 or,
It's a modifier. It's a 95.3 modifier.
okay. All right, so I need that.
Do they have to be physically in New Mexico
No.
for me to do telehealth?
No. So that's another thing is that when they updated when they gave the authorization to make video visits the same as face-to-face visits, it can be across state lines. They do not have to be in your same state.
So my question is on the review of chart and the time spent documenting the visit, that's all one time?
Yep,
And then the
it's all
time
one
spent with
time.
the patient?
Yep.
Okay. And then the modifier, and that's, the modifier is because of the time doing the, I mean, what do you use on your modifier? You said it's a 95.3, but what is that?
So you have a 99214 visit. So
Uh-huh.
then you add a 95.3 and that makes it a video visit.
Okay,
Then you have to document your time, and that EM is the third modifier. Right, so like you have your main code for the visit, you have your modifier that made it a video visit, and then your EM is your total amount of time spent. And that's your third modifier.
all right. And you can put that little note about your time and everything, say like in your AMP. Okay,
Yeah, definitely want to document somewhere in your note how much time you spent.
Hi, do you know what the difference is between telephone and video? Because we've been doing telehealth at my clinic, but a lot of people don't have email or don't have access. It's a huge thing. So basically, all of mine are just phone calls and what are your blood sugars, that kind
Yeah,
of
so
thing.
they bumped up the telephone RVUs, and so the telephonic is about 2/3 of what you get for a video face-to-face. Okay, roughly.
JD, I have a question. Do I, as the provider, need to be in the state of New Mexico at the time of the visit, or can I be in another state?
You can be in another state.
Okay, thank you.
Yeah.
At
And
the
that's-
beach? At the beach?
Yeah.
yes.
Yeah, at the beach, yeah. How we doing on time? Anybody watching my time? Since I'm the timekeeper for all the other sessions. I'm just-
9:43.
Okay, I wanted to blitz through this and give people a lot of time to answer questions.
I work for Presbyterian Healthcare Services. I think a lot of you do too. But we started out with telemedicine and we were told, telephone encounters or video encounters. But in the last, say, 6 months or so, we were alerted that most insurances weren't paying for just a telephone encounter. And we were not allowed to make telephone encounters if their chart had a big red insurance does not pay for telephone encounters, and I'm finding more and more of them. So it's been hard because they can do a video encounter and we are paid the same as a face-to-face. But I was wondering if anybody else has experienced that where you're stopped from doing which is very easy to do a telephone encounter. Most older people that don't know how to use their smartphones or whatever have sometimes difficulty with video encounters unless their child is there and can help them. Are
Yeah.
you guys experiencing that as well? I use
So-
my phone every day on Doximity video encounters. I live in a rural area of Ruidoso. I work in Hondo, which is a small community. And I have a lot of trouble getting the videos to work. I somehow
Yes,
finally do by
yeah.
calling the child.
Bandwidth is an issue. So here's a part of the problem. The insurance companies were not getting the proper documentation. So that is a part of the issue. Somebody says, I made a phone call, give me $15. The insurance company says, I don't care if you made a phone call. You do that all the time. You call patients with their results on this or you whatever. You have to be able to document within your note that goes to the insurance company that you had clinical decision-making, that you spent X amount of time with the patient, and that you do have to check off some of those boxes to make sure that the insurance companies pay it. But the government has been clamping down on insurance companies that have not been paying because they have a declared pandemic. And as long as we are still in a declared pandemic, the government has made it easier for us as providers to get reimbursed for those services. So yes, at first, because there weren't enough telephone codes or there weren't enough video visit codes, and because people didn't know how to properly document, which is part of the reason why I'm doing this talk today, the insurance companies could say, nope, you were just calling with their lab results, that doesn't count. No, I called him with his lab results, his x-ray results, and I changed 2 medications. So that becomes clinical decision-making. So and that's typical Presbyterian pushback because they didn't get the money. But if they would have pursued it that next step, if they would have taught their providers how to do the proper documentation, and then press those insurance companies and say, documentation's here, pay up. So it's still an evolution. I'm not saying it's a perfect system, but you will now be more informed as you go back to your practices to tell your billing and coding people, we need to add these extra steps to see if we can go ahead and get these insurance companies to pay up. Okay, but again, that documentation of clinical decision-making is important. There's one back there.
JD, I have one for you real quick. What are the requirements for security? Encryption and security, there's no security on a telephone call, but what about a video call? I'm calling to the dialysis center and a lot of times I'm doing FaceTime.
So that depends on, who you work for. Of course, I'm in the government. We have to use the government secured system. I can't just make a video visit on Zoom or some other platform. We have to use a secured system. So it really depends on who you work for as to whether or not they provide you with the means to do that. So, honestly, how secure is Zoom? Zoom can be hacked. People can get your, call-in code for a Zoom and they can get into your meeting and they can wreak havoc with it. There are secure platforms out there. And I, encourage you to tell your practice to be able to engage in one of those secure platforms.
Okay, so if I was hearing you correct, when you were saying if you call a patient back, say it's the next day, and you're going over their labs and you're changing medications and you're making a different plan, you can actually bill that out separately?
Yes.
And what code do you use for that?
So again, you use your regular code, like a face-to-face. If you called the patient back in to talk over those things, and then you made changes to their plan. So you use that same code, but then you're going to have to use one of the modifiers
Okay,
to make it a telephonic or a video encounter.
yeah, sometimes those telephone calls last a long time.
Sure. Yeah.
So
You
the other
got-
thing I was going to say to the lady up front is we were using Doxy also. And there would be some calls where, we could see each other. Maybe the patient could hear me, but I couldn't hear them. So I kind of walk them through things, I was looking at them. I could tell that they're breathing well, they're pink, I'd have them, maybe open up their mouth and try to look down their throat. And actually, if you get them close to a window where the sun is shining towards them, you can see
Yes.
really good down their throat. And then I would say, we're going to finish this up on the phone. And then that way you can talk to them about the plan and everything. And we just, still timed it out that way.
Yeah, put in that modifier 95.3 for a video visit, even though you finished it on the phone. That happens a lot. Bandwidth in New Mexico does not support, the video thing as well as it should, and it will eventually, but right now it does not. So I have the same thing happen even on the secured system that the VA has. I'll start out with them. I can see them, they can see me, but they can hear me, I can't hear them. So I'll have the phone and the video on at the same time. So I'm talking to them on their phone. Another thing that I do, of course, I'm ear, nose, and throat. So I had to think about this early on. When I'm looking at my patients remotely, I will tell them to have a spoon and a flashlight so that they can push their tongue down and show me the back of their throat, So different ways, if some of my patients, and I've done this on my own, out of my own money, I will send them one of those little pencil cameras. Match it up with your phone. Here's the instructions. It cost me 25 bucks, or if they can afford it, have them go get one. And you can look at everything, whatever you need. So, yeah. How are we doing on time? I just want to make sure I don't go too long.
I think we're good on time. I think if we need some more questions, we can do that.
Yeah, I mean, it's the up and coming thing. I think, when we talk about this same subject in a couple more years, it's going to evolve farther. And right now, they've extended the official pandemic to the middle of May. So, as long as that time period is in place and we're in official pandemic, the elevated RVUs and reimbursement are still in place for Medicare and Medicaid, and most of the insurance companies that follow those guidelines will follow that for now. So, and I think that they have an incentive to continue the pandemic until they run out of the billions of doses of boosters that they have made. So just saying, I think it's going to go on for a little while yet. We're still going to have to wear masks at work.
Okay, anybody else? Okay, well, with
All right.
that, JD, we'll let you go.
You're out of
Thank you
here
so
early.
much. So we are officially on break. Our break is from 10 until 10:30. So there should be coffee and tea to wake you up, snacks in the back lobby. Be sure to visit the vendors, and we'll meet back here at 10:30 in this room for pins, pumps, and sensors by my friend Vicki Valentine, Virginia.